All right, so let's go ahead and get started. Thank you again for joining today. Like I said, I'm John Payton. I'm the president of Surgical Services for Specialty Care. Definitely am really excited about the topic and the discussion today. I believe many of you are familiar with specialty care. We support over 1,300 hospitals across the country, as well as many ASCs. Like most of you, we certainly understand the growing demand for robotic surgeries, as well as the opportunities that they can bring to your patients, your facilities, and your surgeons alike. Certainly, we know when a robotics program is running well, the data along with the quality and financial benefits are really tough to dispute. Specialty Care supports robotic surgeries in a number of ways, which include surgical first assist, neuromonitoring, and instrument management services, including our sterile processing and minimally invasive OR support offerings and more. We are vendor agnostic in our approach. We're definitely not a manufacturer, and we pride ourselves on focusing on optimization and skill enhancement, and don't really have to worry about selling equipment and supplies. We believe that our approach aligned really well with CAVA's and that it was a natural fit for a strategic partnership. The work that CAVA is doing to enhance sophistication, efficiencies, and optimization within robotics programs is fascinating. They're really a true partner to the hospitals they support, and I don't use the P word lightly. So there's no better team to walk you through this than the CAVA team, led by Josh Feldstein and Dr. Herb Cousins. And with that, I'll kick it over to Josh to introduce CAVA and get us started.
John, thank you. That was very kind, and we feel similarly about the excellent work that Specialty Care does, and we'd like to welcome everybody today to our second masterclass, and we're going to give you some insights on what a 90th percentile robotic surgery program looks like. I will be joined by Dr. Herb Cousins, our medical director. Herb will take a moment to introduce himself, and Dr. Bill Skenderis. Bill is another one of CAVA's medical directors. Bill's a general surgeon. Herb, why don't I start with you, and then you can flip it over to Bill, and then we can get started.
Yeah, so Dr. Herb Cousins, I've been a robotic surgeon in GYN since the early launch of the robot, 2004, 2005, so I'm coming up on 20 years. And then during that time, I've had the opportunity to proctor surgeons, and then for the past 10 years have worked with CAVA to sort of bring that holistic quality approach to surgery, which leads to always efficiency and improved cost.
And I'm Bill Skenderis. I'm a robotic general surgeon focusing mostly on hernias, inguinal and ventral. I've been a robotic surgeon for about probably 7 to 8 years now, and have actually been through the CAVA engagement myself through our hospital, and look forward to participating in this.
Thank you, Bill, and thank you, Herb. So let's see if we can define for everybody today as a starting point what best practice means. We covered this in our first webinar, but I want to restate this so that we have a good groundwork. Now, as an applied health economist with a specialization in robotic surgery, one of the things that we've come to see is that if you want to have a best practice robot program, the costs of robotic surgery really have to be equal to or less than your laparoscopic cases. And that's a pretty interesting and bold statement, because a lot of hospitals are of the opinion that it's really impossible to get robotic surgery to exceed laparoscopic surgery with regard to profitability. But the truth is it absolutely can be accomplished. Quality similarly has to be equal to or better than. So now we're talking about having robotic surgery as a profitable, compared to lap, enterprise, and a high quality clinical exercise relative to laparoscopy. Now, it also stands that robotics should be appropriately used. There are absolutely cases in which robotics and laparoscopic procedures can be used for a similar case. On the other hand, a lot of this is subject to the skills, abilities of the surgeon, the facility, the crew, the specific demands clinically of the patient. So appropriate use of robotics is what we're going to be talking about. But what is very, very important to be aware of at this point is that when you think about minimally invasive surgery today, for the first time, robotic surgery has actually eclipsed laparoscopic surgery in terms of overall case volume. Herb, it would be great if you could speak a little bit about the balance equation between robotic cost and quality versus laparoscopy. It's a very important dynamic.
Yeah, I want to reiterate what Josh said, and that is that in many cases, for instance, in benign hysterectomy and inguinal hernia, and some of the more common cases that are done where there's both laparoscopic and robotic options, robotic surgery is eclipsing laparoscopy now. So implementing robotic surgery in a very responsible, cost-effective way is necessary. Otherwise, we're just driving up the cost of healthcare. And that speaks to the value equation. And we've talked about value in primary care a lot, but not really as much in surgery. So if we take, cost and quality in the numerator and denominator, if we drive up costs, but we don't drive up quality, we're just worsening the value proposition. Whereas if we can improve the quality and lower the cost, we're improving the value. The problem is the literature doesn't really support of strong clinical differentiation between laparoscopy and robotic surgery. So local hospitals really have to work, as Josh said, on their local culture and their capabilities and their surgeon skills to make the decision on which cases would be better suited with laparoscopy and which ones with robotics.
Right. Thank you, Herb. Now, a lot of what Herb just referenced harkens back to literature over the past 10, 15 years in robotics. And for those of you who have been reading the robotic versus laparoscopic peer review literature over the course of the last 15 years, you'll notice that robotic surgery is typically viewed as taking too long and costing too much relative to laparoscopy. And the reality of that is it's due to the fact that many of these papers, many of these studies were conducted based on surgeon experience that was in its relatively early phase, where you had relatively inexperienced crew and surgeons and efficiency and all of that. And the result was the data didn't really show anything compelling. However, over the past 5 or 8 years, that trend has really begun to turn around. And CAVA has published numerous papers in the literature demonstrating, as Herb referenced, in a number of very specific service lines, the real clear difference between robotic and laparoscopic surgery from the standpoint of efficiency as well as cost effectiveness. Now, Bill, as a general surgeon and someone who specializes in bread and butter cases, hernias, let's start with that. Love to hear your perspective as both a robot surgeon and a laparoscopic surgeon when you look at the pros, the cons, the pluses, the minuses between the two.
Well, I think that in terms of laparoscopic hernia surgery, I think, at least in speaking with my patients, and if you look at any quality of life studies that were done regarding inguinal hernia surgery, robotic hernia surgery is certainly less painful, and there's definitely a quicker return to normal activity. Certainly in my practice, I have those patients essentially back at normal activity within 2 weeks, and by 4 weeks, they have absolutely no restrictions. And if one remembers anything about open hernia surgery, that was typically 8 to 12 to 16 weeks before return to normal activity. Even compared to laparoscopic surgery, where the visualization is better in robotics, the manipulation of the tissues and quite frankly, the mesh is significantly improved, which increases to more efficient use of time because the operation actually goes quicker and less tissue injury during the dissection. And those of us that remember when laparoscopy first came into vogue at least in general surgery. Certainly the gynecologists were well ahead of us on that curve. But people were naysaying the laparoscopic cholecystectomy and laparoscopic hernia surgery, and especially laparoscopic appendectomy surgery, which is all three of which are now fairly standard procedures to be done and more popular than their open versions. I think we're seeing the same progression going through robotics. And so I think it's important that we do look at our programs at each hospital and see how we can make them more efficient and more cost effective while maintaining or even improving quality.
So thank you, Bill. So what you're really defining is what a best practice program, a 90th percentile program is thinking about from the standpoint of using robotic surgery across all these various service lines and case types. And when you think about quantifying a best practice program, we use the following filter here at CAVA. Now, there are 21 specific categories that we've defined, and this is from work that we've done in the field, working with hundreds of hospitals over the course of more than a decade. And what we've seen, what makes a hospital's robot program excellent, and where hospitals really have a problem running their program with efficiency and quality and cost effectiveness. And if you look at these 21 specific dimensions, and for those of you who are here today, we will be sharing with you a PDF document that will be sent out from Specialty Care that will enumerate all of these, define them, and give you some guidelines in terms of how to approach them. There are 4 specific categories from ad hoc all the way to what we define as best practice. For the most part, hospitals really, they languish mostly between the red and the orange, which is either there's no specific plan relative to these categories, or they're reactive. Something goes wrong and they try to fix something, and that's normal. That's typically what we see. But what we recommend, if a program has the intention of becoming a best practice program, is that you have to think proactively about all 21 of these categories. You have to have somewhat of a plan to address each individual component here, from vision and strategy to cost effectiveness, to instrument use, to reposables, to training, to simulation, to vendor management, to planning for the future. And so the idea is to try to get initially a program where all 21 of these categories is sitting in what we call the top quartile, 75th percentile or better, and eventually master the program and get to a 90th percentile, a best practice level in all of the categories. That takes a little work, but it is absolutely achievable. We've seen it time and time again with the process that we've just described. So when you think about putting together an ecosystem of robotics, I'd like to address the fact that you really have to have a team approach to putting the program in place. Herb, I'm going to ask if you wouldn't mind to speak a little bit about the idea of a clinical and operational vision and a proactive strategy, and the alignment, most importantly, between administration and clinicians when it comes to building a great program. This is a real hot spot for a lot of hospitals.
Yeah, we've been used to functioning as physicians in like medical staff committee structures where surgeons meet and talk about problems and or clinical topics, and then the nurses and circulators and techs and anesthesia might meet in a separate setting. And administration may not participate in any of those, or they might. And where we are today is that if we're going to implement any kind of change, that change needs to be done collaboratively, because the crew brings valuable knowledge to the table about operations. And from a clinical perspective, the surgeons need to understand that. Similarly, the crew needs to understand about the critical nature of certain clinical steps, and administration has to support the whole process with data and decision support and metrics and measuring, and also holding people accountable for their activities. So it really becomes more of an operational or steering function rather than a medical staff function to get the change that's needed to see the value and top 10 percentile performance.
Yeah. Now, what you're talking about is communication, and I want to emphasize that having really, really, really good communication is a hallmark of a best practice program. Transparency is another critical hallmark. And when you think about transparency and communication, you've really got two very clear principles that define what a best practice top 10th percentile and 90th percentile program really looks like, with the committee providing the kind of quality oversight that we're describing. The other part of it is the continuous improvement process. We start with something called a growth mindset here at CAVA. And what we are looking to define is a perspective of all the stakeholders, surgeons, crew, administration, all the support team, in which the approach of learning and improvement is embedded in the culture of the robotic program. There's always an opportunity to learn, and our surgeons, all of them have done minimally 1,000 robot cases, and many of them have done quite a bit more than that. And yet, even they are learning on a constant basis relative to new experiences and insights. We look at the process of growth mindset as a foundation setter for everybody to approach the building of a really great program. And it starts with these key performance indicators in terms of what cases cost, what instruments cost, what case times are acceptable, what components of case times are best practice, and where there's opportunities for improvement. All of these very specific KPIs are established at the ground of the program, and then the stakeholders can work together collaboratively, auditing their own performance with data to be able to check exactly where they are. And these also include video reviews of cases by surgeons. And Bill and Herb, it would be great if you guys could take a couple of minutes to talk about video case reviews as a really powerful tool.
You can go ahead, Bill. You can start.
Great. Thanks, Herb. And thank you, Josh. I think probably one of the most useful aspects of CAVA engagement is the video review process for the surgeons. It basically, it's sending completely de-identified videos of the robotic procedure that is taken through the Da Vinci robot. And it is stripped of all personal data and then sent to CAVA. And then we take it, and the various surgeons look over that and give little tips and tricks. And as I've stated, certainly to Herb and Josh before, it's not that the reviewers are there to tell you who to operate on or how to operate. The surgeons already know that. We're there to provide any experiences we've had in the past, or just some little tricks or tips that we have heard about or tried ourselves, or what has worked, what hasn't worked, and see if we can improve that process. Can we make it more efficient? Making sure that safety is the top priority. And I think that has really been a hallmark of this engagement for us.
Yeah, and I would add to it, when we were in the age of open surgery, you never really could evaluate what happened in the surgery. Now that we have digital surgery, or even with laparoscopy and robotics, we can record those and capture the video and images and look at that in the rearview mirror for ways to improve. This happens in sports, and in the entire world now is a selfie world, where we're looking at our performance and looking at our experience on video has become part of culture, and it really should become part of surgery also, and because of the ability to learn and improve.
So I would just summarize this point by saying best practice really is about peer-to-peer mentoring. And that means a level of transparency and comfort between your staff, among your staff, working with outside experts, and also within your own environment. You have your own surgical leaders, you have your own luminaries. The idea is to create this environment of growth mindset, of continuous improvement. And all of this leads to a process of annual privileging assessment and decisions that are made with regard to how best to approach the design of privileging. Herb, if you could speak a little bit to the criticality of volume and simulation as also part of continuous improvement, that'd be great.
Yeah, similarly, like we live in a digital surgery world now where, we can record the cases. You can also simulate those cases, both by task-based or procedure-based. And so there's no reason to really be learning on a patient. We can learn in the lab with simulation. And there's plenty of studies that support to surgeons who become proficient at simulation, both task and procedure, have immediately out of the box top 10th percentile performance. And then to maintain that volume is important. Everyone knows that if you want to have your heart done, you go to the heart surgeon who's doing the most of them, not someone who dabbles in heart surgery. So it's the same if we want, quality robotic surgery, is you want to go to a program and a surgeon who does a lot of the cases.
Thank you. So we mentioned a little bit about the team sport concept, and this is something we really feel very, very strongly about when we see a really terrific program anywhere in the United States or even outside of the country. We've seen many examples of this. Let's talk a little bit about the metrics that are involved, the role of a robotics coordinator, super important component of the team, and how the robotic personnel have to work together. I'll flip it over to both of you guys to chime in on this. I know you've got a lot to say about this one.
I'll start with this one. So I like the term the democratization of surgery. So, if I'm a patient, whoever's on call or whatever time of day it is shouldn't really matter as to what level of care I receive if I come in the hospital. So we're to the point now where, in the middle of the night, you can get a laparoscopic cholecystectomy or a laparoscopic appendectomy, but not all hospitals have the ability to offer, a superior technology like robotic surgery for those cases. And so I think we need to, just like Bill described, this evolution of going from open to lap surgery, and we're in the process of evolving into robotic surgery, that everyone's trained to hook up a laparoscope. Everyone should be trained to support robotic surgery. And if you have those tough cases 24/7, you should have access to the technology. And then I'll kind of leave it to Bill to kind of talk about the metrics and a robotics coordinator.
Yeah, when we look at metrics, obviously, when I ask a group of surgeons, how's your turnover time? Every single one of them will say, well, it's too long. And they can't all tell me how long it is, but they can all tell me it's too long. And if you ask the staff that's working in those ORs, how long are your turnovers? They say, we're working as fast as we possibly can. And so I think it takes a coordinated effort between or among all the groups. That includes surgeons, anesthesiologists, nurse anesthetists, and the OR staff, nurses in the operating room, the surgical assistants, the surgical techs. It takes really a coordinated system. And for that, you do need a robotics coordinator, I agree. And that's someone who is the point person where everyone goes when either there's an issue or there's an improvement to be made or something to be looked at needs to go through. And I agree with Josh, of course, but also with Herb in terms of, this is becoming a standard procedure. And so we should be training the entire OR crew, the entire anesthesia group, all of the nursing staff to be able to do robotic surgery day and night, not just from 7 a.m. to 3.
You know, Bill, Herb, I just want to emphasize that in the many of the hospitals that we talk to, when we talk to C-suite, what you're describing is not a commonly held point of view. Uh, when you think about robotic surgery being available 24/7, that's usually met with, wow, I really didn't think of robotic surgery that way. And yet that's sort of the direction that robotic surgery as the tip of the spear of minimally invasive surgical services is now going. So I would suggest that for consideration to all best practice oriented organizations, that thought be something that you percolate on, and it's something really worth discussing with your providers and with your crew leadership. Now,
I would add to that, Josh, think about it from a dollars and cents point of view. You make this investment in all of the equipment, and yet a lot of times we hear that hospitals are struggling to do 250 or more cases, 300 cases a year. And that's because they pigeonhole the robot into a certain room and a certain elective schedule, and then they might do ortho cases in that room and not have access to the robot. Whereas and then at 3 p.m. or 5 p.m. they just shut off access to the robot. Well, if you really want to make that equipment sing and be valuable, well, let's put it to work through many shifts in the day. And do more cases on it. Now we've sort of defrayed the cost of that capital. So it's even a dollars and cents issue, not just a quality issue.
right, and as we mentioned briefly in I think our first webinar, the if you want a metric to look at, 325 cases a year on a robot, typically Intuitive will tell you that you're ready to buy your next robot or have access to your next robot, acquire it somehow. But the message really is that's just the starting point. If you really look at best practice performance, you can get 400, 500, 600, 700 more cases a year out of a robot. And that really is what efficiency looks like. Would you talk about that just a little?
Right. I mean, when you think about there's about 250 weekdays in a year, and even if you only do 2 cases a day on a robot, that's 500 cases a year. So 300 should not be the ceiling.
Exactly, exactly. So just to recap, we're talking about equal to or better than, as we've touched on today, for best practice. You really want to have, in order to have a superior program, more cases on that robot per year. And it means that you may need fewer robots. That could be delaying or even eliminating the need to expand your fleet, which is always something that the C-suite are happy to embrace. And that the more best practice oriented your program is, the lower your med mal exposure. Why? Because you are proactively doing everything you can to pursue quality, to pursue efficiency. And when you use quality and efficiency as your North Star, you are working proactively to build a really, really good program. Now, bad things happen and mistakes happen, they occur. But to take the perspective that the system, the hospital is doing everything it can to make a program excellent, that's always, always a big plus. So we'll be sharing with you through the colleagues at Specialty Care at the conclusion, I believe tomorrow this will be going out, a PDF of the 21 dimensions of best practices. And as we had mentioned the first webinar, if any of you are interested in having our team complimentary review your console data, that will give us some insight into instrument use and prospective cost savings, which can, in a lot of cases, be pretty considerable. We'd be very, very happy to assist you in all of that. So we'll stop here and take questions that you have. And we have already received a very interesting question. I'll pose it to both Dr. Cousins and Dr. Skinderis. And the question is, if our robotic cases cost more than our lap cases, does that mean we're at the 50th percentile or below? It's a great question.
I would say that's relative. So, there are benchmarks that are available nationally. We've accumulated a large amount of data and can share with hospitals what is the 50th percentile for robotic cases compared to other hospitals. It could be your lap cases are high because of surgeon choices of mesh or fibrin sealants or tackers or other instruments that just get thrown in the trash, like ligatures, et cetera. So it's not necessarily a comparison between lap and robot that determines 50th percentile. It's robot to robot, nationally, to what peers are doing and what best practice is.
Thanks. Okay, we have a question pertaining to how long does it take to get all 21 best practice categories into the green zone, and that green zone is the 75th percentile. I'll take a start at that, and that is typically, depending on where the average hospital begins, and let's just say the 50th percentile, which is more or less what you would expect to see if you look at an average program, typically 9 months or so of work usually starts seeing that institution get into the beginning of the green zone. Sustaining that may take some additional months of work, but I would say 6 months you should be getting your infrastructure under you, and by 9 months you should certainly reasonably start seeing the data trend in that direction. Everybody's going to start understanding exactly what they're doing, costs, time, quality metrics, and the components of transparency, communication, and best practices start to congeal at a higher level, and then things start to move. I will ask Herb or Bill if you guys want to provide any commentary on that, or you're satisfied with my answer on that one. Good?
Sounded good to me, Josh.
All right, so it's about 9 months. How's that? Let's look at the next question, and the question reads, you mentioned a few types of procedures, looking at hernia and GYN. Can you briefly share other types of procedures that robotic programs target? And the short answer is just about all of them, but I'll leave it to our surgeons to comment on that.
Want to start, Bill?
Sure. So in general surgery, it could be a number of different ones. Of course, hernia surgery is probably one of the more common intra-abdominal general surgery programs, one of the more common intra-abdominal general surgery procedures that makes itself certainly available to robotic use. And gallbladders certainly are done robotically, and those can be done as efficiently or even more efficiently than laparoscopic cholecystectomies. Bariatric surgery, gastric limiting procedures, sleeve resections for morbid obesity surgery. And then you get into the more complex things, which I don't recommend young programs to begin, things like Whipples and esophagectomies and things like that. Actually, esophagectomies, the dissection goes much better robotically. And then looking at thoracic surgery, certainly there are programs across the country that do wedge resections and lobectomies through robotic surgery. And of course, beginning to do cardiac surgery bypasses with the robot as well. So like Josh said, just about any procedure in a body cavity that you can think to do, certainly laparoscopically or thoracoscopically, can be done with a robot.
And I would add, from the pelvic surgery, both male and female procedures. So, prostatectomy has become pretty standard robotically now compared to open. There wasn't a great option for laparoscopic, but I think when you look at urology procedures, partial nephrectomies, prostatectomies, and really almost any GYN surgery, I haven't opened a patient in over 6 years. So pretty much anything that we can do GYN-wise can be done with a robot. I will add to that is it depends on your surgeon desires, right? Because many hospitals now are finding that residents and fellows coming out of training are trained in the robot, and unless they're supporting these cases, they're going to have trouble hiring surgeons. So it is becoming a standard offering in training programs. Therefore, it needs to be implemented wisely in community programs.
And just one more thing, if I might, I left out, and I can't believe I did this, I left out colon surgery. I mean, colon surgery, certainly a low anterior resection and even a sigmoid resection is actually done with more facility with the robot. And I left it out because my partner is doing most of those in our group. But yeah, I mean, anything you can do in a body cavity with a scope, you can do with a robot.
Right. Bariatric as well, right?
Yeah.
So along that line, and I know, Herb, you're the maven really of the data here, so I'm going to ask you to speak to this. The comparison of robot case volume versus lap case volume overall, when we talk about robot eclipsing lap, if you could speak to that tipping point. And also, where do you see the either service lines or case types specifically where it is more common at this point for a robotic versus a laparoscopic procedure?
Well, I think for sure urology, and very likely general surgery for most of the common cases. Robotics is eclipsing laparoscopy. For I would say for GYN procedures, particularly benign hysterectomy and also malignant hysterectomy, just for uterine cancer, not for cervical or ovarian. So there are, specialty specific areas that have grown more. I think that the future of the more complex surgeries like foregut surgeries that Dr. Skenderis was describing, pancreatic cancer, liver resections, esophagectomies, and thoracic surgery is not quite there, but it's getting there.
Yeah, I think it's generational a little bit too. As you're getting more surgeons coming out of residency with a very strong experience in robotic surgery, you're going to see a lot of these, particularly the more common surgeries, certainly hernia, gallbladder, bariatrics, that are going to be done more so with robotic technology than with straight stick laparoscopy.
There's a lot on the horizon too, like doing thyroid removals with the robot. So not making a big scar right in the neck, but going in through the axilla and getting to the thyroid gland. So there's a lot of creative out-of-the-box thinking on minimally invasive surgery and ways to approach it as people become more comfortable with the technology.
Thank you, guys. We have time, I think, for another question or so, and here's another one that's popped in, and that is, why is peer-to-peer support critical to making a robot program better? Now, that's a really important question. Why is it important for surgeons to work with surgeons to make a robot program a best practice program?
Well, I'm going to pick on Bill. Have you ever seen a surgeon that's going to listen to anyone else?
No.
Us nice
whether it's a peer or
gynecologists,
not.
Us nice gynecologists, we listen to midwives and all kinds of people. We're warm and fuzzy and listen to, we go with the tides.
If you had asked me that question 15 years ago,
there's some element of
understood
truth to that, and that is right. There's some truth to that. I mean, it's very hard for an administrator to understand what goes on in the operating room. Even what we've seen as chief medical officers in hospitals oftentimes are primary care based. And so, having a peer who does the surgery itself and has successfully navigated like a 3-arm, 3-port, 3-instrument, no assistant port case, and gone through understanding how that can be safe and effective, is really the voice that I want to hear. I don't want to hear the manufacturer. I don't want to hear a salesperson or a non-surgeon, explain to me how surgery needs to be done.
Yeah, there's no one that knows about surgery more than another surgeon. There's no one that can help a surgeon more than another surgeon. We quote unquote speak the language. We know how to get through any pre-existing prejudices or anything like that. We know what a surgeon wants to hear, and I think it's good to hear it from up here. I mean, extending the sports metaphor that we talked about earlier, if you've got a second string quarterback that's trying to improve, they're listening to the starting quarterback. And so I think that having that where you have shared experiences and you know kind of what to say and how to say it and what the other surgeon is going through, then I think it helps. And as Herb said, you're not going to listen to a CMO that was in primary care or a hospitalist or an emergency room physician, because nobody knows what being a surgeon is like other than another surgeon.
I would say that the advantage of a program, on the other hand, like we operate with ourselves, we don't know what all other general surgeons are doing in the room, but there is tremendous value from robotics coordinators or surgical assists, because they're in everybody's case. They know what works well, and so there is part of that program is breaking that culture down a little bit to say, why don't you learn from the robotics coordinator as well, what other surgeons are doing. So even though it's the most glorified apprenticeship ever is learning surgery, there is a time to sort of think about it out of the box a little bit differently and involve the team.
Thank you, guys. That was really very interesting to hear the perspective from the inside out. We are about out of time. I'd like to thank everybody for joining today. And before we break and send you back to your activities, don't forget about our third masterclass on June 20th at noon Central. And that is, how specifically do you create this optimized and profitable program? Today, we defined what it looked like from a number of perspectives. And next time, we're going to get into real action steps, what you can do to start getting there for yourself. We'd like to thank once again Specialty Care for sponsoring and supporting our webinar today. We look forward to seeing you guys the next time. And for all of you who are with us today, look forward to sending you out the 21 Dimension Guide. And we stand ready to answer any of your questions if you have them. For Dr. Cousins and Dr. Skinderis, my name is Josh Feldstein from CAVA Robotics. Thank you, John Payton, for hosting, and we wish everybody a good afternoon.
Thank you, guys. Very insightful. Have a great afternoon.